Good morning. I think we're going to start our meeting. First, I'd like to welcome you all to Jeddah and the Sanem 2019 meeting. It's been a lot of positive energy and work to get us here. We'll have the opening ceremony at 11, so I'll keep my comments short and just say welcome, good morning, and I wish you all a very good meeting. And we'll start now with the introductions of the moderators of the first session.
Welcome everybody for Sanem 2019 conference. We will start our first session about muscle disorder. Our chairpersons, Dr. Dr. Omar Wazan. He's a pediatric neurology. He's a neurology consultant at King Faisal Hospital and Research Center in Jeddah. And Dr. Musa Mijalli. He's a neurology consultant and head of neurology department at Hira Hospital in Mecca. And Dr. Inas Al-Muwallad. She is a neurology consultant at East Jeddah Hospital in Jeddah. Please welcome to the stage.
طيب السلام عليكم صباح الخير. Good morning everybody, and it's a very good opportunity to start our event today. Hopefully inshallah it will be enjoyable for everybody. Our first speaker, inshallah, will be Dr. Ziad Mohammed Al-Humaid. Dr. Ziad is a neurology and neuromuscular consultant, assistant professor at King Saud University, a graduate of College of Medicine and King Khalid University Hospital in Riyadh. Please welcome with me Dr. Ziad Mohammed.
Well, good morning. So the original program I got was Dr. Al-Shehri was supposed to be before me, so I thought I have an easy job because Dr. Al-Shehri had to do a good job in warming the audience, but it turned out to be the first speaker. So I'll be speaking today about myositis specific antibodies. So our understanding of myositis have evolved over the years. Initially, there was some, clinical assessment. You see, weakness and under the microscope, some inflammation and high CK, say inflammatory myopathy. Over the years, we got more investigations, more ancillary testing, and that helped in understanding, classifying diseases in a better way. One of those ancillary testing is myositis antibodies, which I'm going to be speaking about today. All right, so in general, I like antibody testing, and I think they are an attractive testing, okay? And I think they're attractive because relatively they're non-invasive, especially in myositis antibody, when comparing with muscle biopsy or other procedures. They don't require in situ expertise. You just draw some blood, put it in a tube, and you can send it to whatever center that run these tests. They're relatively non-expensive. They can help with diagnosis and prognosis. I'm going to show you later in subsequent slides. So when you review literature, there are two myositis antibodies. There's myositis-specific antibodies and myositis-associated antibodies. So, as the name implies, the myositis-specific antibodies have very high specificity for myositis, 90% specific for myositis, and they target a key process in cell biology. Whereas the myositis-associated antibodies, they're non-disease specific, as I'm going to show you. I'm not going to talk about it a lot because it's not the core of the topic. But mostly you see these with scleroderma-associated myositis. And once you see them positive, you may see them with other myositis-specific antibodies. So they don't carry huge weight in evaluating myositis patients. So this is the classification I'm going to go by for now as my presentation. Subsequent talks, we'll talk about it in details. So we have the dermatomyositis, immune-mediated necrotizing myopathy, the IBM overlap myositis, and the query polymyositis if it really exists. All right, so one slide on dermatomyositis as I'm starting the talk. So the dermatomyositis, they have the typical skin manifestation, which will be explained later talks. They have the classic myopathy with the symmetric proximal. You have the high CK of around median of 800s to 1000. And you have the classic pathology of perifascicular atrophy. So you have the atrophy at the edges of the fascicle, and sometimes see MRI enhancement, especially around the muscle. You may have it, a pure myopathy with no skin manifestation, but you see the perifascicular atrophy, and vice versa. You may see only the skin manifestation with no clinical myopathy, but the biopsy is telling. All right. So 70% of patients with dermatomyositis have myositis-specific antibodies. So I'm going to talk about these 4 antibodies, and each of them have a unique characteristic and can help you with diagnosis or a prognosis. So the first antibody I'm going to talk about is the MI2 antibody. Okay? It targets a nuclear antigen. So this antibody, once you see it, it usually gives you the classic dermatomyositis, okay? So the skin, the muscle, the high CK, the whole thing, okay? But the only difference here is they saw a couple of patients, they may have severe weakness at the onset of the disease. So if you see this figure, I don't know if it's clear or not, okay? So this is a preliminary data. This was presented in the ICNMD in Vienna, okay? So they compared 3 categories of patients, all right? So this is SRP myopathy, which is immune-mediated nucleotizing myopathy. We know this variant is really bad. They start really in bad shape, and they don't get better, okay? They're usually really in a bad shape. The line in the middle is our MI2 dermatomyositis patient, and the line on top is the TIF dermatomyositis patient, okay? If you go by this axis, the lower you go here, the worse you are in terms of muscle strength. So if you see the MI2 patients, when they first start in the initial clinical visits, okay, they are really in a bad shape. But, in 1 year or around that year, you see the clear separation between the SRP, and in 2 to 3 years, they catch up to TIF1. So they might have severe weakness at the beginning, but gives you classic dermatomyositis. Okay, so classic dermatomyositis might have severe weakness at the onset, should not scare anyone, mostly they get better. The second antibody is a very, very interesting antibody, the NXP2 antibody, okay? So this is a very unique clinical syndrome. So as opposed to most of the dermatomyositis patients, these patients have more distal weakness than proximal weakness. As far as I know, I've never heard of such a presentation for dermatomyositis. Okay, they usually involve the extensors more than flexors. They have subcutaneous edema and calcinosis, and it's highly associated with cancers. So let me show you a case presented in the ICNMD. Okay, so this is a case that Dr. Mammon saw. Okay, so this is a 40-year-old lady. She has the classic dermatomyositis skin rash, but she has a 2/5 power in the finger extensors with 4+ power in the biceps and triceps. If you see here, he's doing the whole arm is edematous and it's pitting edema. And guess what? The legs does not have any edema at all. So you have severe edema in both of the upper limbs up to the shoulder with nothing in the legs. Okay, it's very, very unique. So this is the NXP antibody, okay? So calcinosis, subcutaneous edema, and distal more than proximal weakness, highly associated with cancers. The next antibody is the MDA5, okay? So this antibody is highly associated with skin manifestation of dermatomyositis. Usually these patients are amyopathic or hypomyopathic, okay? The characteristic thing about this antibody, the halotrope or the gotrons that you usually see in this antibody, you see them ulcerate. So you see ulceration in the gotrons or halotrope, as you see in the figure. There's ulceration in the lady eye or in the fingers, so it gives you ulceration. And this antibody is highly associated with a severe interstitial lung disease. This is a case reviewed in the literature. So this is a case of skin manifestation of dermato, some ulcerations in the areas where you have the rash, and the lung is completely gone. Severe interstitial lung fibrosis. So MDA 5, amyopathy, mostly skin manifestation of dermato with ulcerations and severe interstitial lung disease. Finally, the TIF1 antibody of dermatomyositis. So again, it have the skin more than muscle, typical dermatomyositis skin, amyopathic or hypomyopathic, very high association with cancer. Okay. So this study was done in John Hopkins. So they have 213 dermatomyositis patients. They wanted to see what's the cancer, how many people had cancer in this group, cancer-associated myositis, and then check the antibodies and see which is which. So 29 out of 213 have cancer-associated myositis, and guess what? 9 of them had NXP2 and 15 had TIF1. So the bottom line, if you see a dermatomyositis patient with positive TIF1 or NXP2, be very careful and vigilant about cancer screening in these patients. All right, so just a quick review before we go to the next category. So the MI2 antibody have classic dermatomyositis, might be severe at the beginning. NXP2, they have subcutaneous edema. They may have calcinosis. The weakness is distal and high associated with cancer. MDA5, amyopathy, most skin manifestation, but ulceration in the site of the halotrope. And they have a very severe interstitial lung disease. And finally, TIF1, again, have typical skin manifestation of dermato and high associated with cancer. And these antibodies, please be careful and screen your patient. Once you see them, have vigilantly screened them at least for 3 years for cancers. All right, we'll go on to the next category of diseases, the immune myopathy with immune myositis necrotizing myopathy. So again, these patients have the classic subacute weakness, proximal more than distal. These group of patients have a very high CK. Actually, this the highest CK among all inflammatory myopathies. In the study, the median CK was 4,700. It goes up and down, as opposed to the classic dermatomyositis just show you was 700. And in the next category, I'll show you what's the CK. Their muscle biopsy is very characteristic. So you see a lot of necrosis and regeneration. Okay, so a lot of necrosis and regeneration in the muscle biopsy, which is not perivesicular, and you don't see lymphocytes. So if somebody is inexperienced, they might shrug their shoulder and not an inflammation, okay? But this is have severe necrosis and regeneration. These patients, if they're not treated early on, they don't do well. Sometimes you see even the connective tissue is very widened. So two-thirds of these patients have myositis-specific antibodies, okay? And 1/3 don't have antibodies. So the classic 2 antibodies are SRP and the HMGCR, okay? So I'm gonna contrast the two, okay? So the SRP usually is not associated with a statin, where HMGCR, most of our MCQs, statin, you get HMGCR, okay? There's high association, not causation. The muscle weakness is very severe in SRP as compared to HMGCR. The necrosis is expectedly more severe in SRP than HMGCR, and the CK is much higher in SRP than HMGCR, although both of them are high. Interstitial lung disease is more than HMGCR, and the cancers is more in the HMGCR group, okay? So this sums up the SRP versus HMGCR immune-mediated necrotizing myopathies. So what about the 1/3 that don't have antibodies? So these are actually the ones that you have to be very careful with, okay? Because most of the cancers happen in the antibody-negative group, okay? So if you see somebody with a very high CK, with a subacute progression, and the muscle biopsy that shows you active necrosis, regeneration with no lymphocytes, so you're in this group, and it's negative for SRP and HMGCR, have to be very careful about cancer in this group. Okay, so we'll move on to the overlap myositis, which is the third category of diseases. So these are autoimmune myopathy that are associated with other connective tissue disease. SLE, Sjogren's, scleroderma, etc. Okay, so the big category is the anti-synthetase syndrome. Okay, the anti-amino acyl tRNA synthetase. They have one or more of the following characteristics. Okay, so they either come with inflammatory myopathy, interstitial lung disease, arthritis, Raynaud phenomena, fever, mechanic's hand, or the skin lesion of dermatomyositis. Okay, so the anti-synthetase group, okay, they may present as a regular dermatomyositis, and you think you get a dermatomyositis case. Okay, so they may have the typical skin manifestation, they may have the typical clinical phenotype, and you think you're on dermatomyositis, okay? Once you biopsy them, you're gonna notice a huge difference, okay? So these patients who have a severe necrosis and regeneration at the edges of the fascicles, okay? So the classic dermatomyositis, they have just perivascular atrophy, whereas this group, they have active necrosis and regeneration in the perivascular region. And expectedly, the CK will be much higher in this group as compared to the dermatomyositis. So the median CK in this group is around 1400, whereas in the classic dermatomyositis around 700. Okay, so they have perivascular necrosis and regeneration. All right. So three antibodies characteristically described in the anti-synthetase syndrome. So okay, so I lumped the anti-PL17 and PL12 together, because I think they more or less have similar characteristics, and I'll contrast them to anti-Jo1. Okay, anti-Jo1 is a very classic antibody and been described before all of these. So the anti-Jo1, 90% of those patients, they have muscle involvement, okay? And they have severe weakness when compared to the anti-PL17 and PL12, whereas the other group, PL17, PL12, mostly 50% of them, they don't have even muscle involvement. Mostly interstitial lung disease, and they're very severe interstitial lung disease, okay? So anti-Jo1 mostly muscle, not a lot of interstitial lung disease when compared to the other antibodies, okay? PL17, PL12, they may come to the pulmonology clinic, okay? Rather than the neuromuscular. Severe interstitial lung disease. Right. So as I said, they may come, this group of diseases, the anti-synthetase, they may come like just a dermatomyositis, but you know, the biopsy is different. Right. So the last group I'm going to talk about is the sporadic inclusion body myositis, okay? So very, very unique clinical syndrome, okay? So they present with the age of more than 50. Most of the autoimmune disease, they come at a young age, but this disease never comes below 50 unless you have HIV or something. They usually, as opposed to other immune myopathies, the progression is over years. The other immune myopathies progress over weeks or months. This one over years. The characteristic is of the weakness is asymmetric, and most of the immune myopathies are symmetric process. This distribution also is flexors in the hands and quadriceps, and this is again a very unique finding. So the clinical here, the clinical syndrome is very telling. Although early on it may be confused with a lot of diseases, but once you have the full picture, it's very telling. You may get an EMG and CK and muscle MRI. It might help you tell you this is a myopathy, although the EMG sometimes can be combined with denervation of the myopathy. The muscle biopsy also is a very characteristic of the syndrome, okay? So you see, it's going to be described more, but you're going to see this focal invasion. So the muscle is still viable and alive, and you see these lymphocytes just making a track here and eating the muscle, chewing the muscle while it's alive. You see vacuoles on the Gomori and the Cox negative, and see some aggregates. So bottom line is muscle biopsy. If you biopsy the right muscle, it's very telling. All right. The antibody is anti-C5-1A, and I'm not very happy about that antibody, okay? So it's present in 30-60% of IBM patients, but unfortunately, it's present in a lot of other diseases. So it can be present in polymyositis, 20% in dermatomyositis, you might see it present with other antibodies, 10% in SLE, in Sjogren's, so not very helpful. If you see a patient where it's a wish-washy and you're not very sure about diagnosis and you get it, this may add a layer of confidence that that's what you're dealing with. I wouldn't rely completely on this antibody to diagnose the disease of IBM, purely on this antibody. If you see people with so if you see somebody with, you think IBM, okay, with a clinical presentation and the whole thing, okay, and you see the anti-C5-1A antibody positive, okay? These patients usually have a they have a severe disease and increased mortality when you compare them with NTC51A negative IBM patients, okay? So that might be a little bit helpful when you prognosticate for patients, but I wouldn't rely on it completely for diagnosis of this condition. And I'm not going to talk about polymyositis because there's a lot of doubt on even if it exists. And that's all. Thank you.
Thank you. Good morning. Thank you, Dr. Ziad, for this lecture. We'll keep the questions to the end of the session. It's my pleasure to call next speaker, Dr. Arif Bushnag. She's going to speak about the inflammatory myopathy classification and treatment updates. Dr. Bushnag, she is a consultant neurologist, neuromuscular, working in the International Medical Center in Jeddah. Please welcome Dr. Arif.
Thank you for giving me the chance to present in this meeting. And unfortunately, I'm going to repeat a lot of what Dr. Ziad have said. You cannot differentiate the antibodies from the classification and of inflammatory myopathies. So I'm going to talk about the classification of inflammatory myopathy and the management. I'll have a brief introduction followed by the classification, the criteria for the diagnosis, and then the management. So inflammatory myopathies are a heterogeneous group of rare diseases that affect multiple organs. It can affect the muscles, the skin, the lungs, and the joints. The classification includes the dermatomyositis, the immune-mediated necrotizing myositis, the sporadic inclusion body myositis, antisynthetase syndrome, overlap myositis, and polymyositis. For the dermatomyositis, it can present at any age, usually with weakness and skin manifestations. They characteristically present in a subacute way within weeks to months. There is subtypes of dermatomyositis known as the clinically amyopathic dermatomyositis, as mentioned before. Those patients usually present with skin manifestations with no muscle involvement, or they can have just minimal muscle involvement known as the hypomyopathic dermatomyositis. And in the other spectrum, there is the adermatomyopathic dermatomyositis. Those patients would present with the weakness and the other manifestations and would have no skin involvement. So these are the different skin manifestations in dermatomyositis. You can see here the hyperemia and edema of the with purplish discoloration of the eyelids. This is known as the heliotropic rash. Erythema in the neck and the upper chest. This is the Schawel sign. When the hyperemia involves the anterior neck and it's the Phi sign. Having some papules with reddish and purple-like discoloration over areas of skin stretching, such as over the joints. This is known as the Gottrin's papule. Erythema with no papular rash is known as the Gottrin's sign. And then they can also present with periungual erythema and telangiectasia as well. So 70% of patients with dermatomyositis will have dermatomyositis-specific autoantibodies, which are associated with unique clinical subtypes. There's 5 antibodies that are important to recognize in cases of dermatomyositis, as mentioned by Dr. Ziad. The anti-MI2 antibody, it usually has a better response to treatment, good prognosis, and it carries a low risk of malignancy. The anti-NXP2 carries a high risk of malignancy. They have severe skin manifestations in the form of calcinosis. They can have the distal weakness and dysphagia as well. The anti-TIF1 antibody, they have strong association with cancer, so it's important to recognize them. They can present with the amyopathic dermatomyositis, and they can have also the dysphagia as well. Then there's the anti-SAE antibody. This is mostly reported in the Japanese population, and it has high incidence of cancer. And then there's the anti-MDA5 antibody. In those patients, they have very severe skin manifestations, and as we have seen in the previous presentation, they can present with skin ulcers and necrosis, and they have a very lethal form of interstitial lung disease. So it's important to recognize it for the management. The typical cases of dermatomyositis would present with elevated muscle enzymes, myopathic EMG changes with fibrillation potentials and positive sharp waves. The MRI would show high signal intensities in T2 weighted images with the characteristic involvement around the muscle fiber itself because of the involvement of the fascia. The muscle biopsy would show the perivesicular atrophy and expression of the human myxovirus resistant protein, and I will leave that for the following presentation on the pathology. The other type of immune-mediated neuropathies is the necrotizing myositis. So those patients usually present with severe proximal and distal weakness, high muscle enzymes, myopathic EMG changes. They have the necrosis and regeneration of the muscle fibers and minimal lymphocytic infiltrates, but they do not have any perivesicular atrophy. The extramuscular manifestations are usually rare in this category. 2/3 of patients with the immune-mediated necrotizing myopathy do have antibodies, and these are the anti-SRP and the anti-HMGCR. 20% of patients who do have these antibodies will have lymphocytic infiltrates in their muscle biopsies. If the patient is positive for the antibodies, there is no need to do the muscle biopsy anymore. But if the patient did not show any antibodies, then a muscle biopsy is still needed to confirm the diagnosis. So why do we do it? It's for the clinical characteristics. The anti-SRP antibodies can present in addition to the severe weakness with dysphagia, and 20% of the patients would have the lung manifestations. Anti-HMGCR is associated usually with the statin exposure. The antibody-negative patients are the most important because they have a very strong association with cancer. Then there's the sporadic inclusion body myositis, which is the most common myopathy in men after the age of 50 years. It has a characteristic slow progressive course, and it's usually asymmetrical. They have a special pattern of involvement with weakness of the knee extensors, and they have weakness also of the long finger and the wrist extensors, and weakness of dorsiflexor. And they can have progressive difficulty in swallowing as well. 30 to 60% of those patients have an antibody, which is the anti-NT5C1A, and it's associated with a more severe disease and high mortality. But this antibody is not specific, and it's found in other diseases. There's no clear evidence up to now that any immunosuppression would benefit patients with sporadic inclusion body myositis. And by MRI imaging, they have characteristic findings with selective involvement of the anterior compartment of the thigh. As you can see here, the vastus lateralis and vastus medialis do show some atrophy and fatty replacement, but characteristically, it tends to spare the quadriceps femoris muscle. Then there's the anti-synthetase syndrome. This is the myositis associated with transfer RNA synthetase. The most common antibodies in these categories is the anti-Jo, anti-PL7, and anti-PL12. For anti-Jo, the most important is that 90% of those patients do have a myopathy, and not all anti-synthetase patients would have myopathy. So the PL7 and PL12, 50% of them would present with interstitial lung disease with no muscle weakness. Other features for the anti-synthase are the interstitial lung disease. They can have the constitutional symptoms in the form of fever, weight loss. They can have severe non-erosive arthritis, which is at times misdiagnosed as rheumatoid arthritis. They can have the Raynaud's phenomena, in addition to the mechanic hands, which is scaly erythematous skin changes that involves the ulnar surface of the index and the radial surface of the thumb finger. They usually present, if they have the muscle involvement, they will present with proximal muscle weakness, elevated muscle enzymes, the same changes in the MRI with high signal intensities. It's not specific. It indicates that there is an edema and underlying inflammation. The muscle biopsy characteristically shows perivesicular atrophy similar to dermatomyositis, but they also have increased number of perivesicular necrotic muscle fibers. The overlap myositis is an autoimmune myopathy associated with other connective tissue diseases, either the SLE, Sjogren's, scleroderma, or rheumatoid arthritis. 50% of patients who are in this category would have positive serological antibodies for the mixed connective tissue disease, but usually they do not have the symptoms, and with continuous follow-up, symptoms of the mixed connective tissue disease would appear. Then the polymyositis, it's a diagnosis of exclusion. They have proximal weakness, high muscle enzymes, myopathic EMG, and inflammatory CD8 T cells in their muscle biopsies. So all patients with inflammatory myopathies should be screened for malignancy. Malignancy occurs in 25% of dermatomyositis patients, 10% of polymyositis, and it's also reported in the other necrotizing myopathies. Most of the malignancies are usually diagnosed within the first year, but the diagnosis can be confirmed up to 5 years as well. Breast and ovarian cancer are the most common in women. Lung and prostate cancer is the most common in men. And other malignancies include lymphoma, cancer colon, pancreas, and bladder. So the European Federation for Neurological Societies have recommended to screen dermatomyositis patients for malignancy using the CT chest and abdomen, ultrasound, pelvis, mammography, testicular ultrasound, colonoscopy in patients older than 50 years of age. If the primary screening was negative, then a repeated test should be done in 3 to 6 months. And then screening is recommended every 6 months for a total of 4 years. Periodic tumor markers can also be checked. Now I'm going to move to the classification criteria of inflammatory muscle disease. So there is a huge classification. The first classification was introduced in 1970 by Medasger. Then in 1975, the famous Bohen and Peter criteria was introduced. And it was followed for about 40 years. Throughout the 40 years, there was some modifications in these criteria. And their criteria, the first thing is to exclude other myopathies. It included poly and dermatomyositis mainly. They had 4 items in their classification. To diagnose polymyositis, the first 4 items, which are the weakness, the biopsy, the typical biopsy findings, the muscle enzymes, and the EMG features, had to be present. For probable, 3 items are needed, and for possible, 2. For the dermatomyositis, a 5th item is added, and it's always fixed and has to be present. The 5th, in addition to 3 other items, would give a definitive diagnosis of dermatomyositis. 2 items are probable, and 1 would be possible dermatomyositis. In 2004, they decided to start working on developing a new criteria to classify immune-mediated inflammatory myopathies. And they started the work on developing this criteria in 2004, and it was actually released only in 2017. So here they included the American and the European Rheumatology Society were involved. It was multi-center, international physicians were involved. They included dermatologists, neurologists, rheumatologists, epidemiologists, and biostatisticians. They had a total of 16 variables in the criteria. Each variable was given a score based on calculation in statistics. I cannot go over that. They have 2 scoring systems, one without muscle biopsy and one with muscle biopsy. The one without muscle biopsy is used for patients with dermatomyositis in whom they had the typical skin manifestations and a muscle biopsy was not needed. But the majority of those patients had a skin biopsy which did show the intravesicular dermatitis, which is characteristic of the dermatomyositis. They had an aggregate score, so the sum of all these scores would give us the probability of the inflammatory myopathies. They have placed a cutoff point of 55% as the number for having a probable myositis. That's regarding the criteria. But the criteria did have some limitations. There's some variables that were not included in the initial assessment of this criteria, such as the MRI findings and the myositis-specific autoantibodies. They did not include the MRI findings because it was not available for many patients, so they decided just to keep it away. And the myositis-specific antibodies were only limited. We have only the anti-Jo here. Immune-mediated necrotizing myopathy and antisynthetase are not included as a separate category, and they included them only under the title of polymyositis. And some of the muscular dystrophies can be misclassified as inflammatory myopathies. So now I'll go to the management of idiopathic inflammatory myopathies. So there's no standard guidelines to follow in managing the myositis, and that's because of the lack of randomized controlled trials, the rarity of the disease, and the different subtypes. So we are following only expert opinion and case series. Glucocorticoids still remain the main medication to use initially. It reduces the inflammation, and 60% of patients would show signs of improvement within 6 months. It's given at a dose of 1 milligram per kg per day. In severe myositis, pulse steroid can be given, and then the target is to taper it over 60 months to the minimal dose possible. IVIG was tested in a randomized
2 minutes. Please.
2 minutes? Okay. So IVIG was also tested and was proven to be effective. It was placed in the American Academy guidelines in 2012. There is a systematic literature review where they reviewed 308 patients and they found that it was beneficial to use. There is a subcutaneous form of IVIG that can be also used, and it's effective. It's used on a weekly basis through a pump. There is a new study about IVIG that will be released tomorrow. It's in March 2019. Then the immunosuppressive agents, I'm not going to go over them. So it's the methotrexate, azathioprine combination therapy, calcineurin inhibitors, mycophenolate mofetils. The cyclophosphamide is usually reversed for the severe myositis with rapidly progressive interstitial lung disease, overlap vasculitis, and patients with refractory to therapy with the second and third line. It's given IV or orally, and the limited use is because of its toxicity and the risk of malignancy. So the biologic agents are more specific, and they target specific immune targets, immune cells and cytokines. There's a number of biologic agents that have been approved, had been studied in inflammatory myopathies, mostly the rituximab, which acts mainly on the B cells. There is the rituximab in treatment of refractory adult and juvenile dermatomyositis and polymyositis. This is a randomized placebo trial. They had primary and secondary endpoints. Unfortunately, their primary and secondary endpoints of improvement was not reached, but from this study, they found that 83% of patients did show improvement when they do not follow the way that the study was designed. So they found that rituximab is really beneficial, and its further studies are needed. There's a study specifically in the anti-SRP, and it was also promising. Etanercept and abatacept also have good results, and further studies are being done. And we're still waiting for the tocilizumab study to be released in 2020. So there's the ENMC International Workshop in 2016 had placed guidelines for the management of immune-mediated necrotizing myositis. And here, for the anti-SRP myopathy and anti-HMG-CR myopathy, the first-line treatment is always steroid, either oral or pulse steroid, depending on the severity of the symptoms. And then at the same time, or after 1 month, you can start the second or third-line agent. You can start, the methotrexate was recommended in both groups. In addition to the methotrexate, for the anti-SRP, rituximab can be added at the same time, or it can, in addition to the methotrexate, if it's severe, or instead of the methotrexate. So you can judge that according to the severity of the patients. For the anti-HMG-CR, they recommended after the methotrexate to add IVIG with it, or to substitute the methotrexate with IVIG, depending on the severity. And in some patients, use only IVIG if there's contraindication to use the steroids. So what about the maintenance therapy? When you find that the patients have started to get the maximum improvement, then the target is to start tapering the steroids off. The second and third line agents should continue until the patient is stabilized and is in well-controlled disease for 2 years. And it's only after 2 years of controlled disease that the medication should be tapered slowly. In HMG-CR, they found that they probably would need to be contained on a small dose of maintenance treatment. So this is another way of giving the treatments as first and second and third line. I'm not going to go over them. There is evidence that exercise would improve patients with myositis. It was first reported in 1998 in patients who have myositis, chronic myositis, and are stable. And new studies have confirmed that even patients with acute myositis may benefit also from limited exercise. Thank you.
Thank you, Dr. Arif, for this excellent presentation, and actually it was nice cover up. We'll move to the next speaker.
Next speaker, it's my pleasure to introduce Dr. Murad Abdel Karim At-Turkestani. He's Assistant Professor and Consultant of Pathology at King Abdulaziz University Hospital, Jeddah. Please welcome Dr. Murad Abdel Karim. He's gonna give us a talk about histopathological feature of inflammatory myopathy.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. First, I would like to thank the organizing committee, particularly Dr. Aisha, for this invitation and this excellent conference. And thanks for the chair for introducing me. In the next 20 minutes, we will review together the pathological features in inflammatory myopathy. And we will concentrate on some historical perspective, different classification already introduced by Dr. Arij, and concentrating on the histopathological features on the muscle on these conditions. So it's already shown, and that's, we know the muscle pathology is way before 1970, but it's 1975, the original paper talking about subclassifying polymyositis from dermatomyositis, and I think at that time it was very easy. For neurologists, the only things you need to show is there is a skin manifestation to call it dermatomyositis, and already all these skin manifestations has been discussed. Before talking about the muscle pathology, I have to talk briefly about normal histology of the muscle. So we have here the normal fascicles of the muscles. In the fascicles, it's arranged in it's very difficult to point. Anyway, the muscle fibers will arrange in small fascicles. We have the spaces between the small fascicles, and this is the endomysiums, and then we have slightly larger spaces surrounding the perifascicles, and this is called the perimysium. In the perimysium, we can see some large vessels, not in each perimysium, but some of the perimysiums, while capillaries will present between the small muscle fibers. Before I'm going through the pathology, I just will mention that we are going through the history, but when presenting the histological features, I will just combine all the knowledge we know just to save time. So in polymyositis, the cardinal features described is actually invasion of the normal muscles by lymphocytes. And first I have to clarify the word inflammatory myopathy. Where does it come from? So inflammatory myopathy, that does mean there is an inflammation in the muscles. And the inflammation here, we talk about chronic inflammation. In the chronic inflammation, the most important cell will be lymphocytes. And lymphocytes, we classify them to B and T lymphocytes. We also have other features that help us to classify these diseases as inflammatory. We're looking for complement depositions. We're looking for MHC class 1 expression. And in these muscles, if we look, we can find a single pale fibers with the asterisks. And this pale fiber is actually necrotic fibers. And this one you should ignore inflammatory myopathy, because necrotizing fibers or necrotic fibers will have secondary inflammation. It will have the macrophages come and engulf and clean the area. So we cannot classify inflammatory myopathy based on that alone. We should have inflammation. And here we talk about the lymphocytes. So the other one, the other muscles with the other muscle fibers with on the right, we can see it is normal. It does look like its neighbors, but it is invaded by lymphocytes. And that's what we need to call it really inflammatory myopathies, invading the normal muscle fibers. If we do subclassify these lymphocytes, then in polymyositis we'll find the main cell will be T lymphocytes. There will be CD8 positive cells. And if we do MHC expression, we'll find that in normal muscle fibers that MHC expression is limited to the capillaries. However, with inflammatory myopathies, we see increased MHC expression in both the membrane and the cytoplasm of these muscle fibers. In contrast, for dermatomyositis, the main pathology actually it is in the perifascicular areas. In the perifascicular, we can find the perimysiums is slightly increased with more fibrosis. And if we concentrate, we can see all these atrophic fibers. We can see all these atrophic fibers distributed at the periphery, and that's what we call perifascicular distribution. And still we have the inflammatory cells, which we said we need them for calling inflammatory myopathies, but the inflammatory cells in dermatomyositis usually concentrated around the blood vessels. So we think of it like a vasculopathy rather than real muscle disease, because the pathology most likely affecting the vessels. And what we see, the perifascicular atrophy, it may be related to the blood perfusion. So these areas usually have low blood perfusion. So if the vessels are affected, this is maybe a secondary phenomenon. We see the perifascicular atrophy in this characteristic distribution. And if we concentrate on this, we can highlight the perifasciculars with some immunostains, as we can see in the upper picture. We can see that most of the perifascicular muscle fibers are atrophic. And if we want to subclassify the inflammatory cells here, in contrast to polymyositis, it's CD4 rather than CD8 cells predominating, and we can have some B cells in the inflammatory component. We have complement depositions, also attesting this is indeed an inflammatory condition. Ultrastructurally, if we concentrate on the vessels, we can see vascular changes, we can see some thickening of the basal membrane, we can see capillary loss, and also we can see the characteristic inclusions, which is called tubular reticular inclusions. It is characteristic, but it's not as specific as it's present in other conditions. Going back to the historical perspectives, that's from 1975. Then in 1990s and 2000s, we have the inclusion body myositis has been introduced to the literature with its pathological features. And in inclusion body myositis, the morphological features really resemble the polymyositis. We can see the same features we already talked about. The necrotic intact fibers are infiltrated by the lymphocytes, and it's basically in the endomysium. However, in addition to these features, we can see some rimmed vacuoles and depositions of congruent positive material. And the name of inclusion body myositis come from the nuclear inclusions. That's only we can see with the ultrastructural examination, and it is thought to be specific. If we find these inclusions, this is an inclusion body myositis. The pathogenesis has been debated. Is it really an inflammatory myopathy? Is it really autoimmune, or it is something else? And these questions come from the other features we see in inclusion body myositis. Most of these cases, we can find some degree of mitochondrial pathology, as the COX will be negative in some cases, reduced by SDH, and that's indicating some form of mitochondrial myopathy. MHC expression is increased in the muscles, cytoplasm, and the membranes, indicating that's maybe indeed more an inflammatory. However, the interesting part, actually, the protein accumulations, we saw the Congo red, it's deposited in these fibers, and then we subclassify these proteins. It could be SMI31, P62, ubiquitin, or TDP43. And these are the same inclusions, the same protein we see with neurodegenerative diseases in the brain. So all neurodegenerative diseases in the brain usually you have protein depositions, and it's the same protein are deposited in these muscle fibers. And also we have some rare associations of frontotemporal lobar degeneration with sporadic inclusion body myositis, telling us, yes, there may be a correlation between these diseases. And so the pathogenesis has been debated, either on autoimmune disease because of the inflammatory cells, because of the MHC expressions, complement depositions, all of those attesting this is indeed an inflammatory conditions, and it is autoimmune, and now we have the new autoantibodies in these cases, or is it degenerative because of all the protein accumulation? I think this doesn't matter that much, because what does matter is for the patients. We know that steroid and immunosuppression will not work with those patients, so immune therapies not working, it's indicating it's not really only autoimmune disease. It has something else to that, which is most likely a degenerative disease. Then in 2003 and 2004, peculiar disease has been introduced into the literatures in the inflammatory myopathies, and that's the immune-mediated necrotizing myopathy. And this is very interesting, because before that, when we see necrotizing fibers, we don't think about inflammatory myopathies for the reason we just discussed. For inflammatory, I need the inflammatory cells. And here, in most cases, you don't see much of the inflammatory cells, and the cardinal features, it is necrosis, necrotizing, scattered necrotizing fibers. So this is what we concentrated earlier. It's only necrosis, and the inflammation here is secondary to the necrosis. So there is no inflammatory cells attacking the muscles in these conditions. And it is important when we see this condition, we don't call it right away immune-mediated necrotizing myopathy. We should exclude the more common conditions, especially for neurologists. Most of the time you find the patient with a statin, so this is considered a toxin-induced and statin-induced necrotizing myopathy. If the patient has history of infection, rhabdomyolysis, and some form of limb-girdle muscular dystrophy. However, some cases, when studied more carefully, they found MHC expressions is there, and complement deposition is there. And if we study some cases carefully, doing more levels, we can find lymphocytes in up to 20% and maybe more, depending on how much time you spend on these muscles. So all of these really supporting this is really an autoimmune, or subtype of necrotizing myopathy is really autoimmune and should be included in the autoimmune disease in the inflammatory myopathies, even if we don't see the lymphocytes. And what is more supportive, of course, the autoantibodies discovered in these diseases, the anti-SRP and anti-HMG-CR, already discussed by my colleagues before me. Then we have other classification moving through the years, and this is very interesting classification, I would say, and this is in 2005, because this classification actually they're trying to get rid of the neuropathologists, saying, okay, we don't need the muscle biopsy, we will depend mainly on the autoantibodies. And it has some truth to that. The fact is, antibodies already discussed by my colleagues, they are more specific, and it's not just specific, they give us more information. So under the same spectrum, if I'm talking about dermatomyositis, just for example, we have 5 different antibodies. These different antibodies will predict different clinical scenario, different association with the interstitial lung disease, and the association of malignancy. And I think this is maybe more important for the patient and physician than just diagnosing a dermatomyositis. We really need these antibodies to subclassify them, and it is not limited to dermatomyositis. We can see it in all other conditions. So we need these antibodies, that's for sure. However, if you go to the frequency, just the table just beside it, it's not perfect, it's not 100%. So if you depend only on the antibodies, we will miss a lot of the cases. And also more important is you will miss the mimickers of inflammatory myopathies. It's not a straightforward diagnosis. You have to exclude other conditions before reaching a pathological diagnosis. So I think this publication was not accepted in the literature, and you cannot get rid of us yet, and still we are in business. So these are the basic and the most important classical pathological features of the more common conditions of of the inflammatory myopathies. But we have different classifications, and it is evolving. So we have many classifications, many people coming with new consensus criteria. The only one I will discuss, because it is particularly very nice, is based on classification in 2011. And he's very famous for his website, Neuromuscular, which I think most of us are familiar with that. It's what I have to warn you before going through this classification. It has been introduced in 2011. However, major textbook in neuropathology and muscle pathology after that, after 2011, did not adopt this classification. I don't know why. I really, personally, I think it is very nice. It gives us more information and it should be adopted. So if we go through the classification, you will forget about all the condition you just heard about. If you're looking for a diagnosis, first, it is a pathological classification. It depends on the pathology and pathological features in specific compartments, and he come up with different 6 criteria, 6 classification. But if you go and look for dermatomyositis, it is not there. Polymyositis, inclusion body myositis, it is not there. It's not in the classification. So what happened to those? Dermatomyositis actually has been subclassified into 2 conditions: immune myopathy with perimysial pathology and myovascular pathology. And if you just remember, when we talk about dermatomyositis, we say the most important features is the perivascular distribution of the pathology, and the second important thing is actually the vascular pathology, when you call it myovasculopathy. So here, instead of calling, if you don't using this classification, most likely those cases will be signed out as dermatomyositis. But if you use this classification, you can subclassify them to the immune myopathy with perimysial pathology or myovasculopathy. So why it is important? Actually, this is predicting different antibodies. So if you use the perimysial pathology, most likely you will find the anti-transfer RNAs indicating this is an antisynthetase syndrome. And we know the association with antisynthetase syndrome is already discussed. So, and if you use the myovasculopathy, this is more the classical dermatomyositis we know. So for me, this is actually more important. It incorporated the new knowledge we know from the clinical, from the serum, from the antibodies and the associations, and trying to go back to the muscle pathology, gaining muscle biopsy, gaining more information, and subclassify them in a way predicting the clinical and the autoantibodies. The same thing if we go to the inclusion body myositis and polymyositis we just discussed, it is not there. What he introduced actually, it is in the last one, it is inflammatory myopathies with vacuoles, aggregate, and mitochondrial pathology, and this is what we discussed. These are the features of inclusion body myositis. But why he didn't call it inclusion body myositis? Because, as mentioned but does not discuss, is actually the entity of polymyositis is slightly become obsolete. It's maybe there, it is maybe there, however it is not as prevalent as previously thought. So what happened to this entity? What happens actually, it's many times it may be misdiagnosed. Other entities really mimic this entity, so we have to exclude other condition, and specifically inclusion body myositis. We just mentioned inclusion body myositis have the same features, the pathological features. It have endomysial lymphocytes, and it have the invasion of the intact fibers by the lymphocytes, most of the time CD4 lymphocytes. So this is the same feature, similar features in inclusion body myositis and in polymyositis. However, in inclusion body myositis, we see the other features, which is the inclusions, the rimmed vacuoles, and mitochondrial pathology. However, in early stage of polymyositis, early stage of inclusion body myositis, these features may be not there, and these cases will easily be called as polymyositis. So if you have a case of polymyositis that's not responding to steroids, and you just happen to biopsy at the early stage and the pathologist did not see these features, he will call it polymyositis. Not responding to steroid, rethink about this case and maybe rebiopsy the patients at later stage, looking specifically for the other features, for the protein aggregations, for the vacuoles, for the nuclear inclusions, and maybe this will be reclassified as inclusion body myositis or something else. However, polymyositis is still there, but maybe rare prevalence, or maybe in the future we'll know it is really obsolete and it's not there anymore. So this is a very nice attempt and to get more information from muscle biopsy, and that's what I like it. It has been introduced by Dr. Pestrunk, who's very well known, but it's not limited to him. This is other people also rethought about the integrations between the muscle, and what they did, they went back to the muscle biopsies already diagnosed as dermatomyositis. Now they know the antibodies. They went back to the biopsy trying to get more information, and what happened, yes, they can get more information, and it happened that these antibodies may associate with some features in dermatomyositis. Some of them will be more prominent with this antibody, other will be less prominent with this antibody. However, this is really preliminary work, and of course, to be accepted and validated, we need a large number of cases, but I think this is the future of muscle pathology. It's not just limited to what we know from many decades ago. It's only dermatomyositis, polymyositis, including bodymyositis, and now necrotizing myopathies. The better idea actually to use of all the new knowledge, the antibodies, going back to the muscle pathology, trying to get more information, have better understanding of the pathology, which will lead to better understanding of pathogenesis and hopefully for the patients better treatment. And with that, I thank you.
Okay, sorry for the technical issue. Okay, so back to Duchenne muscular dystrophy. These are my disclosures. For those of you who are not very familiar with Duchenne muscular dystrophy and neuromuscular disorders in general, this is a nice scheme where you have all the 400 and more different neuromuscular diseases containing one or two. And the Duchenne muscular dystrophy is just at the far end here, okay? So it's just one single condition out of 400 or 600. Duchenne muscular dystrophy has been reported many decades ago on Duchenne, but not only Duchenne, there are also other Italian, British, and other prominent clinicians who describe this. And for many years, nothing happened, okay? Until 1987 or 1986, where the gene for Duchenne muscular dystrophy was cloned, okay, in the USA, giving rise to this new concept of dystrophin deficiency in muscular dystrophy. And again, it took us almost 30 years before having a clue to therapeutic approaches. And what is very exciting now is that in 2018, we have at least 2 drugs approved either by FDA in the States or by EMA in Europe for muscular dystrophy. So that's great news, and we're going to see that in the second part of the lecture. The truth is that for Duchenne muscular dystrophy, we're now living a very different era where things have totally changed. First of all, there's more awareness among professionals, but also among families, and that's new, among biopharmers. As you could see in the next room, when there are more and more companies interested in the field, there are more drugs, there are more. And it's true, it's a great change for most families that we have a reliable genetic counselor. In other words, we don't see, at least in Europe, those large families with 3 or 4 kids affected with Duchenne muscular dystrophy, obviously. Then the standards of care have changed quite a lot. We have now guidelines. They're more or less applied to every situation, but still, it's there, it's available. And there's kind of a consensus among experts about that. And aging of patients is a reality, as you will see in a minute. We have patients over 40, 45, 50. Of course, there are exceptions. But there are genuine Duchenne boys who became adults and will survive quite long. And as we will see in the final talk, we have now novel drugs, novel therapies, either available or on the horizon. Okay, regarding the phenotype, I think most of you are clinicians, so how do we recognize such a disease? First of all, that's very common. Okay, so you're likely to meet some of these kids in your professional life, that's for sure. If you're a child neurologist, obviously, but also if you're an adult neurology dealing with aging Duchenne patients. First of all, it's a rather common disease, okay? The incidence is one birth, one affected male out of 3,000, roughly 4,000 live male births. Again, and we'll insist on that, it's a progressive disease. Okay? Could be slowly progressive or rapidly progressive, depends really on the situation. It's a proximal weakness of muscular origin. The age of onset is usually around 3-4 years of age. And the first symptoms are mostly pelvic. Okay, that's the lower limbs are affected, while the upper limbs are usually preserved till late in life. Now, another interesting clue is the pseudohypertrophy. In other words, most of these kids have big calves. And it's good to see, because it's an important clue, it's easy. Then obviously, as disease progresses, these kids will have more and more proximal weakness, and around age 10, 12, and they will start having so much difficulty to walk that they will stop walking and will be in a wheelchair. And if you don't do nothing, if you don't prescribe anything, any steroids whatsoever, these kids are going to die early, and by age 20 or so, on average. They will not survive because of cardiac and respiratory complications.
There are metabolic symptoms such as exercise intolerance, isolated exercise intolerance and so on for years and years, and it could be Duchenne, or it could be dystrophin deficiency, and so on. So I will not list all of them, but still. And we do have an issue too with what I call the discrepancy between genotype and phenotype. As you will see, regarding a molecular diagnosis of Duchenne muscular dystrophy, we can say whether it's an in-frame or an out-frame mutation leading to a Duchenne phenotype or to a Becker phenotype. Okay, that's the rule. But there are exceptions to the rule. And among the exceptions we have is that, for instance, when the genotype tells you, oh, it looks like Duchenne, but the phenotype is not Duchenne. It could be Becker, it could be milder, okay, and just vice versa. So be careful when interpreting the genetic analysis. Okay? Obviously, you need to trust the lab, but if your gut feeling as a clinician is that it's some Duchenne phenotype, then it's probably Duchenne. Okay, what can we do in the lab regarding diagnosis? That's pretty easy. The message here is that the CK are always very, very elevated, in the thousands. Okay, perhaps later in life, especially when the child is very much crippled and with no muscle left at all, then the CK may be just decreasing, sometimes to the normal value. But in the beginning, the CK are always high. And even at birth, they're extremely high. That's why people are saying, well, perhaps we could just detect Duchenne muscular dystrophy in newborns. But that's another issue that we may address too. What about EMG? Well, it doesn't help much, because I'm going to tell you that it's myogenic, okay? And then comes the issue of muscle biopsy. Years ago, we used to biopsy these kids. It was good things to confirm, or at least to visualize the abscess of dystrophin. But nowadays, because of NGS, because of MLPA, very few kids got a muscle biopsy in first line. Okay, that's like this, okay? So you need to rely on genetic analysis. So, regarding genetics, it's an excellent disorder, that's for sure. Never forget that the female carriers, which are approximately 1/3 of the cases, they are symptomatic. Mothers may present symptoms like proximal weakness or cramps whatsoever. Okay, so where is the dystrophin? Dystrophin is part of the muscle, obviously. It's this protein, an orange at the bottom. And this protein is a key protein in the membrane, or close to the membrane, muscle membrane. It interacts with other players in the region, okay, the sarcoglycans, also laminate to, and also sorts of proteins loss. And most probably dystrophin is a shock absorber. Okay? So it's essential for the muscle fiber to survive. Otherwise, it's damaged and it degenerates. Okay, so that's the basic knowledge about X-linked recessive disorders. So Duchenne is a paradigm for X-linked disorders. So males are affected. Okay, females are not supposed to be affected, but some they may present symptoms, as I told you. So what about this dystrophin? Okay, dystrophin is this green protein. You have a normal gene, whereas there's no mutation, and then therefore you have a full-length protein, and you're happy, and your muscle is happy too. Once you have a mutation within the gene, then it depends, because there are all sorts of different mutations. Okay, the ones we know and the ones who are the most frequent are the deletions. It means a small piece of DNA is missing, 1 exon, 2 exons, 3 exons, sometimes more. Okay? Therefore, the protein in the end will not be perfect. And that's why the muscle will be damaged. Another example, apart from deletions, is the so-called duplications. Again, we have here not an absence but an excess of DNA. It may have 1 or 2 exons, for example. Then comes the third situation where we have so-called point mutations. Okay? Just as a tiny change of letters, okay, of nucleotides, leading to an absence or a very decreased form of dystrophy. I'm telling you this because personalized medicine is based on that. Personalized therapy of Duchenne muscular dystrophy targets each specific mutation. If it's a deletion, well, okay, we have to discuss which exons are missing, can we target some exons, and so on. If it's a point mutation, perhaps it might be amenable to the so-called antilurin, which go through the stop codon and so on. Okay? So, in other words, each kid with Duchenne muscular dystrophy nowadays should have a molecular diagnosis. Hopefully, it's now easier than in the past. We do have NGS studies, we have MLP techniques and so on. But there might be some very, very few cases, like 1 or 2% of cases, where it's extremely difficult to say which mutation is at stake. It's the so-called cryptic exonic mutations, but it's been Now, what about the natural history? I told you it's progressive disease, that's for sure. I do insist on the very early stages of the disease, where it's just a floppy, it might be a floppy child or a lazy child. Mom might have observed some symptoms as well. Or just because the child has a speech delay, cognitive delay, or something like that. Yes, that's another case. So we do insist now on this minor symptoms. Why are we doing so? It's because we need, collectively, to diagnose these kids earlier than we did in the past. Okay? Because all these new drugs I'm going to talk about only work if they're given early. You just give them when the child is 6, 7, 8, it's probably too late, or they will work less. So we really need to be active in diagnosis of these kids early. So obviously the natural history is there. These kids are going to have difficulties to walk, to run, to climb stairs. They will fall very often. And there comes the time where they will lose ambulation because it's going to be very difficult for them to walk. Then will come respiratory issues first, and then cardiac issues. But for that, we do have now standards of care. We can be very proactive and treat these complications. So that actually the natural history is now changing. As I said, many of those kids now become adults, sometimes pretty old adults as well. After I was kicked the video, I don't get to escape the presentation, so let me tell you a few words about the differentials. This is the list. When you face a kid with high CK, proximal weakness, I told you, yes, you must think that Duchenne muscular dystrophy. But if your molecular diagnosis is negative, what else could it be? And you have the list there. Congenital muscular dystrophies, yes. FKRP deficiency, yes. Especially in the region, because in the Middle East, FKRP are quite common. Then we have the other forms of muscular dystrophy, so-called sarcoglycan deficiencies. Yes, there are plenty, all around. And so on and on. So there is an overlap between Duchenne muscular dystrophy and other forms of muscular dystrophy, especially limb-girdle muscular dystrophy as a whole, or congenital muscular dystrophy. But think about other diseases, even like Pompe disease and Antonio will probably tell us, especially in the Becker muscular dystrophy forms. Yes, it could be differential and so on. Even SMA type 3, which is supposed to be a neurogenic disorder, may mimic proximal weakness and therefore Becker or muscular dystrophy, so be careful about it. And obviously, as I told you, any neurodevelopmental disorder may mimic Duchenne muscular dystrophy, so think about it and ask for CK in all these situations. Hopefully, and because of NGS now, because of this molecular approach, it's easier for us to screen them and to find culprit genes in those cases. In other words, and so we're specific to the region, people may think that because we live in a place where there's much consanguinity, where there are a lot of consanguineous families, and this is the case here in this family from Kuwait that we studied years back, you may expect to have a lot of sarcoglycan deficiencies or limb-girdle muscular dystrophy. And the answer is no. Actually, Duchenne muscular dystrophy is always the most common disease everywhere in the world, irrespective of the degree of consanguinity. Now, remember, and to make it short, we do have a definition, we do have rules regarding the genetic data. Okay? When you have an in-frame deletion, okay, it means that you will produce a little bit of dystrophin, and therefore the phenotype will be mild, telling you that it's probably a Becker muscular dystrophy. On the other side, if it's a out-of-frame mutation, out-of-frame deletion, then the dystrophin will be 0, or almost 0, and therefore the phenotype will be much relatively stable. And you need to have, and this is a clue for clinicians, you need to have this table in your room, on your desk, because nowadays everyone will ask you, my kid is having exon 45 deletion, is my child amenable to treatment? And therefore you need to rely on this table, so it's widely available. Okay, so that was about diagnosis. Common, pretty easy, but there are pitfalls. Now, what about standards of care? Standards of care is the way you manage patients. We've done that for decades. Okay? Some success. We try to ventilate these kids, we try to alleviate symptoms and so on. We did it empirically, and nowadays we have to do it scientifically. And we're doing it as a consensus. So as you probably know, there are many bodies in the world dealing with such consensus, especially within the Treat NMD, the network, we'll talk about. And therefore experts agree, more or less, but they agree, basically, on what to do when you have a kid with Duchenne muscular dystrophy. So all this has been published just last year, in 2018. 3 parts, so it's a huge piece of information that you need to read. And these guidelines address every single sector of management: respiration, heart, nutrition, orthopedics, physiotherapy, and so on. It's very comprehensive. The main issue is not about the standards of care themselves, that's fine. The issue is about applying this standards of care, because it depends on multiple parameters. The way you're organized, the way you have access or no to physiotherapy, for instance, the mindsets of people, cultural differences, the way people react to steroids, for instance. I know in the Middle East, steroids have very bad reputation, but still, it's part of the gold standard. We're going to see that. Okay. So again, these are guidelines. Try to apply them. Try to customize them based on your own setting, but it's essential. So again, 3 papers in Lancet. It was actually a revision of what has been published in 2010. And another point is, because some of you, most of you are scientists in a sense. So everyone's telling me, are all the standards of care based on evidence, scientific evidence? And it's not that true, because it's more an expert consensus rather than a clinical trial for each of the guidelines. So keep this in mind, but still, there is consensus. And it's true that we're dealing with a fast-moving target. The landscape vision of this document is underway, thanks to PTC and Jen Fong. And you have this imperatives as well. So all this is available. Coming soon is a website, like a chat room for parents and families who want to know more about the disease, about Duchenne muscular dystrophy. And thanks to that, hopefully patients will survive longer, they will be more comfortable, the quality of life will be good, and they will gain life. And they will gain many years of life, like 10 years, as I said. Our patients now are aging. They're aging even like the doctors too. So we have an issue. So the final 5 minutes or so, let me tell you a bit about what's in the pipeline. There are multiple avenues to explore regarding Duchenne muscular dystrophy. I told you about point mutations, about exon skipping, that's true, but there are many more that are listed here. You can target every step of the dystrophic process here. So we have a series of different approaches, okay, based on gene therapy, cell therapy, pharmacology, could be existing pharmacology, like steroids I mentioned, there are many others, myostatin blockers, antifibrotic compounds, ACE inhibitors, even idebenab. Tamoxifen is now, it's much hype about tamoxifen because it seems to be active on Duchenne as well. And there are many others. Okay? Now, let me tell you a bit about exon skipping. That was the situation years ago where we had 3 drugs competing regarding exon skipping and point mutations. The first one has actually died because there were no scientific, well, the data they produced was not enough and the toxicity, the safety was not there. So, trisoplacin is gone, forget it. The only one left is erythropoietin. It's manufactured by Sarepta. It's given IV every week. So believe it's working for the family to go to the hospital every week. But it's approved, at least in the States. But it's not approved in Europe. So we don't have access to it. You guys have access to it, at least in Saudi Arabia and in other neighboring countries, but we have an issue. And Atalurin, as you know, is available now, in large scale, almost everywhere, but it's approved in Europe, but not in the United States, for some reason. This is the pipeline we have for Duchenne muscular dystrophy. That's impressive. So many drugs, so many clinical trials. Some are very promising, very exciting, others are disappointing, but that's life. So nobody knows who's going to win the next step. But we're sure we're going to have it. And the second message is that we're probably going to combine these drugs together. Okay, so
Coming back to exon skipping, I guess you all know this. If you give a specific piece of DNA or RNA, you can skip, you can bridge a gap between two exons.
therefore you can produce not a full-length protein, but at least something promising. So we have this epiplursen by Sarepta. They've had clinical trials underway, and it's been approved by FDA now. Parents have lobbied very much the FDA to have the drug approved. It was a year or 2 years ago. That was very well attended, and they won, and the company won as well. So, coming back to exon skipping, keep in mind that so far, most companies are targeting exon 51, because that's where there are many patients. But Sarepta, for instance, also targets other exons, like 53 and 45. And again, clinical trials are underway, and they're going to submit their dossier for approval very soon. Told you about Toleran, so there's not much left to say, except that it's safe. It's obviously expensive, but that's not an issue here. And this is the way it works. Just a piece of chemistry given orally, that's very easy, and it helps to prolong at least ambulation to some extent. And this is the data we have in the first clinical trials. Okay, 2 more words. Forget about that one. This one has been stopped. Myostatin blockers, yes. Again, there are many trials in the pipeline. And I'd like to spend just 30 seconds about gamma-rolone, which is a very exciting compound because it's not yet approved. But there's many clinical trials on the way. Vision, DMD. And this compound is just like a steroid, but without side effects. So it might be a miracle drug for Duchenne, honestly. So we are very excited about the further developments. So that's the way it works. We can rely on the scientific application. So it's different from prednisone, but they share some targets within the cell. So these are the clinical program development and so on. Stem cells. Stem cells. That's an issue. We obviously say, well, that's nonsense. That's non-scientific. But at the same time, most families, those who can afford it, they go to Ukraine, they go to Russia, they go to China. They used to go to China because now it's over. Because they want to have it. But it doesn't work. It's not scientific. Even though I do believe, and many other experts do believe in stem cells as a potential for the future, but so far, the commercial use of stem cells is not good. Okay, and that's the final slide, Mr. Chairman. What about this very exciting avenue too, which is microdystrophy or mini-dystrophy? As you may remember, the DMD gene is a huge gene composed of 79 exons. It's one of the largest genes in the genome. But hopefully, the central part of it, well, it's a road domain, it's repetitive pieces of DNA, and sometimes we can get rid of it without impacting that much the function of the protein. That's what people have done in the past, and now, is trying to reduce the size of the protein, just keeping the key elements of the protein. That's why nowadays we have the mini-dystrophy, the microdystrophy, which are now used in clinical trials. And why is it so? Because we showed, well, not we, many other people showed that you can use this. You can take a transgene with a shorter version of the dystrophin, put it in a virus, and put the whole into the muscle fiber. That's visible. It's been done in the cells, and that's been done in dogs with Duchenne muscular dystrophy. It works perfectly. They reproduce, they regenerate dystrophin. And there are now clinical trials underway. There are at least 3 companies, Sarepta, Solid Science, and Pfizer being involved in this. We don't know yet whether it's going to be successful, but it looks very, very promising. Okay, so minidystrophy and the microdystrophy. Another one, but this is more science fiction, is the so-called gene editing, you probably heard of. This is Henry Carlson, for instance, in Texas, using the CRISPR-Cas9 system. Again, it's wonderful. It's a molecular scissor capable of cutting the mutation and putting back the right gene, so that's fantastic. And they've done that in mice. This is the paper. They've done it too in dogs. So again, this looks very, very promising, and I'm pretty sure they're going to work on a clinical trial very soon. So this is my conclusion for DMD. 30 years of successful achievements. Yes, that's great. We've done a lot. We have standards of care. We have at least 2 compounds approved and many more in the pipeline. Good news. We have more farmers interested. Great. And the way we work is very interesting because we work together. Not only experts, not only physicians, but pharma companies, patients, advocates are working together. And that's good. Now, we do have challenges. We do have challenges. Efficacy. Efficacy is not always there. It's limited efficacy compared to SMA, for instance, as we'll see tomorrow. And so on. Outcome measures and so on. So we do have challenges to face for the very near future. But we do have hope for hope. Okay? خلاص. شكرا كثير for your attention.
Thank you very much, Dr. Now I would like to invite the other speakers, Dr. Humaid, Dr. Boshmak, and Dr. Turkestani, to be on the stage for a 10-minute discussion and questions. I understand there will be 4 chairs here. I must say the chair that you can provide another extra chair. Any questions? Guys.
Thank you very much. Very interesting presentation. I was just interested in the Lancet study in 2018, where they treated the group with steroids and another group, I assume, they were not treated. How did they ethically justify that? I mean, we know that this agent works. So how did they conduct the study? Just to be curious.
So remember, I showed in Sign-Gene network study, saying that it might have raised ethical issues between those under treatment and those not under treatment, but actually, never forget that even in the States, approximately 15% of the kids are not on steroids because parents don't want to have it. So actually, it was pretty easy. There was no ethical issues at all. We just compared, well, they compared those with and those without steroids.
I am Professor Vantetti. I'm from Tunisia. Thank you very much, Anthony, for, as usual, very nice and clear presentation. I have a practical question because we are not living in the same area and the same population. If you have a Duchenne and we remove for him a LPA and we didn't found deletion or any duplication, other things, it's normal. Did you go to quantitative research or did you do muscle biopsy to be sure that it's Duchenne?
Hello. Nowadays, okay, I would certainly suggest to have DMD sequencing, DMD gene sequencing as a second line, and then if the sequencing, the regular sequencing is negative, I would go for a muscle biopsy.
So 2 comments. First of all, I do encourage everyone to move away, and I have great respect for Dr. Duchenne, but I think it's about time we move away from the pseudo-hypertrophy, because it is a true hypertrophy, and I think we have MRI evidence. It is a true hypertrophy that is depleted or replaced with fatty tissue, and that's where the pseudo-hypertrophy description came from. The second thing, I actually have to agree with the doctor who raised the question about ethical concerns. The clinical trial for steroids was published in the New England Journal in 1989 by Jerry Mendel and the CIDD group. And there are some of us who are in the neuromuscular world who may not necessarily agree with the clinical trials that were conducted, including the 4DMD clinical trial looking at different steroid protocols. And we felt that it has been accomplished. We know that steroids is the first drug that has altered the natural history of Duchenne muscular dystrophy. And then many of the findings really just corroborated the CIDD group. So I do agree that there have been some ethical concerns that were raised, but the number of patients obviously in the volume is a lot more than that was published in 1989. So those are just two comments, but one other thing, and I appreciate your comment about the stigma about steroids, and I wonder if it would be at all useful to remind families that if you are interested in eteplirsen or microdystrophin, all these therapies, being on steroids is a requirement to be eligible for these therapies. And I don't know if that will be more effective or not, but you have more experience in the region.
You're absolutely right. I mean, just my personal experience in Kuwait, where I do go regularly, the only way to sell steroids to families is when you have a drug like atolurin or eteplirsen. You're telling them if you want to access these drugs, you need to be on steroids. And they do accept. The trick is that they do accept for 6 months. And after 6 months, it just stop because it's all like steroids.
Hi, this is Dr. Adna. My question to Dr. Andoni, I have 2 questions actually. The first question is, we know that testosterone has a vital role in promoting skeletal muscle mass, and I don't know, is there any role of testosterone replacement in DMD patients? Second question, how frequently do you do echo in DMD patients, and when do you start ACE therapy?
Could you repeat the second question?
Yeah, how frequent do you do echo? Echocardiogram.
Oh, echo.
DMD patients. And when do you start ACE inhibitors?
So, regarding hormonal therapy, testosterone, and other drugs like this, it's been tried already. Xandrone, it's been tried unsuccessfully. But most probably, there's still new medications. I mean, tamoxifen, in a sense, is like an hormonal therapy too, okay? And this seems to work quite well. So, but testosterone, so I would not recommend. Now, regarding chronic issues, an EKG, an echo every year to start with is mandatory in all these kids. At least at the age of diagnosis, and then on a regular basis. Then when it becomes more an issue, like having an early cardiomyopathy, then you can ask for a cardio MRI to be more precise. But if you do at least one echo every year, that would be good to start with. Dr. Sanem.
I have a question to Dr. Tikastani. Regarding the role of interferon-1-mediated upregulation of genes in dermatomyositis in particular, what's your experience on this? Have you had any clinical experience in doing routine MX1 staining? And have you seen any difference between cases of dermatomyositis with different myositis-specific antibodies in terms of how frequent you would see MX1 expression in these cases?
Yeah, thank you for the question. First, I have to admit, since I came to Saudi, there is no experience because basically we don't do muscle biopsies in our university hospital. For technical reason, that is not started, but hopefully it will start soon. But we can, you can go back to the literature. It's actually, there are nice attempts to correlate clinical, serological, and the pathology, but it's like it's only a few cases, maybe some serious, single serious, is not yet there. We will need more information to talk about these more comfortably and attest and validate these results. It's there in the literature, but I think it's preliminary, and I think this is the future of the muscle pathology. It should not be limited only to the older ones, the dermatopolymyositis. We should go back and review all these cases with correlations with the serology, clinical association, and it's happening, but I think it's preliminary. We are not there yet, from my experience.
This is the last question.
Thank you, Professor Albani, for this lecture. I have a comment that means accepted from my side. It's about possible patient with muscular dystrophy. So, if he's a boy and you think it's Duchenne muscular dystrophy, in the past we were doing muscle biopsy, and if dystrophy is not there, we are going for MMBA or for deletion indication. If we get, we go for sequencing. But I think nowadays with the era, for example, sequencing, especially in our community where we have high autosomal recessive disorders with many muscular dystrophies, I think the sequence should be reversed. We are not doing muscle biopsy anymore. And if he's a boy, we'll go for MMBA. If it's negative, I think the next test is the whole exome sequencing, because that will target all other possible muscular dystrophies with like muscular dystrophies or other ones.
Yeah, you're right. And again, I said it's 1 to 2% of kids where there's no dystrophy at all if you perform a muscle biopsy, but DNA sequencing is negative. And it might be a very subtle mutation within an intron, with an intronic mutation. And for this, you need to extract the RNA from the muscle biopsy. And this again is not available everywhere. So we do have cases which are extremely difficult, and for which there are only a few labs in the world capable of doing that.
This was the last session. I'd like to thank our speakers, our chairpersons. I'd like to ask Dr. Edward to take a photo and to give them their present. So please.